भैया हम निकल गए थे, भैया समय में पूछ रहे थे।
Can we start, sir?
Good evening, sir.
Sir, good evening. We were waiting for you, sir.
Yeah, I was wait 30.
Yes.
Good evening.
Good evening, sir.
Good evening, sir.
Good evening, sir.
Good evening, you all, sir.
Yeah, good evening.
Good evening, sir.
Good evening. Sir, good evening.
Good evening, sir. I am Dr. Indurkar, sir, from
Yeah.
Riva.
Good evening, sir.
How are you?
Good evening, Dr. Manoj.
Just 1 minute, sir.
Yeah,
Yes, sir.
we can
Yes,
start.
sir. Start, sir. Just, sir. Oh. Supriyo, sir, again. Yes. So, good evening, all the respected dignitaries, our guests, all the delegates to the new initiative of RSSDI Bihar. We are organizing monthly online CME in between. So on behalf of RSSDI Bihar team, I welcome you all. I welcome our dynamic president RSSDI, Dr. Professor Vijay Viswanathan sir, who is very instrumental, and his words are always encouraging in organizing such activities. We feel more energetic with his encouraging words. I also welcome our dynamic chairman, Dr. Supriyo Mukherjee sir, for this wonderful CME. And this CME is his brainchild. He usually takes pain for organizing such CMEs and is always instrumental in organizing such CMEs. I also welcome Dr. B.K. Singh sir, EC member, East Zone member, Dr. B.K. Singh sir, who is the doyen in RSSDI Bihar. I also welcome Dr. Manoj Indurkar sir, Professor BSSMCH Reva. Welcome sir in this virtual CME of RSSDI Bihar.
Thank you, sir.
I welcome Dr. Lakhan Singh sir, Professor and HOD SIMS Bilaspur and Secretary RSSDI Chhattisgarh. Welcome sir for this initiative of RSSDI Bihar.
Thank you.
And we are
Thank you.
fortunate
Thank you.
enough to
Thank you very much. Thank you very much, sir.
I welcome Dr. Sanjeev Medhi sir, who is an alumni of AFMC Pune and a chief consultant at Tatkasa Healthcare Guwahati, and is also chairman-elect RSSDI Assam chapter. Welcome Medhi sir for this wonderful CME this evening. I think Sanjeev Medhi sir has joined already. I also welcome Dr. Sandeep Devashish Mishra, a consultant diabetologist at AIM DHC Cuttack, and is also a chapter treasurer of Odisha chapter. I welcome Dr. Professor in MGM Medical College, Kishan. I also welcome Dr. Sehwal Subhash sir, our Vice Chairman, RSSDI Bihar. So without any further delay, I would like to invite all of you to lamp lighting and Saraswati Vandana. Anandji, please facilitate.
देतु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीम् वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीम् बुद्धिप्रदां शारदाम्
Thank you, Anandji. Now I welcome our chapter chairman, Dr. Supriyo Mukherjee sir, for his welcome address. Over to you, sir, Dr. Supriyo Mukherjee sir, our chapter chairman.
You are muted, boss. You are muted. Supriyo sir.
Please unmute, sir. Sir, please unmute.
Not audible. Not audible.
Please unmute, sir.
No, he is unmuted, but it's not audible.
Okay.
Hello.
And no audible.
Supriyo sir,
Hello.
yes,
Yes, audible
yes,
now.
sir. You are
Please
audible
go ahead,
now.
sir.
Maybe he's from a mobile, I think.
You are audible now, Supriyo sir. Please go ahead.
Supriyo sir.
Am I audible?
Yes, sir. Yes, sir. Please go ahead, sir.
Yes, you are audible. Please go
Am
ahead.
I audible?
Yes, sir.
Am I
Audible,
audible?
sir. Audible,
Yeah,
sir.
you're
Please go
audible.
ahead, sir.
Yes.
But I'm not
You-
listening to
yes,
you.
you
Yes,
are.
sir. Please go ahead, sir.
I'm not I cannot listen to you.
Go ahead, go ahead. Actually, is better. Go ahead, go
Yes,
ahead.
sir. Please go ahead, sir.
Hello.
Sir, please go ahead, sir. You are audible, sir.
Hello. Hello.
Now you're muted.
Again muted.
Now you are muted again. Muted.
Unmute करो.
Unmute yourself, sir.
Yeah.
Hello.
Sir. Yes,
Yeah.
sir. Yes, sir.
Sorry.
Yes, sir.
On behalf of RSSDI Bihar chapter, I extend a very warm welcome to you all for today's virtual CME. We are privileged to have with us our esteemed National President, Dr. Vijay Vishwanathan, sir, our inspiration, along with Dr. Sanjeev Medhi, Professor Lakhan Singh, Professor Manoj Indulkar, Dr. Sanjeev D. Mishra, Dr. Atul Baid, our spirited East Zone member, Dr. B.K. Singh sir, our chapter chair-elect, Dr. Shehwal Guha, Vice Chair, Dr. Subhash Kumar, Treasurer, Dr. Manish Kumar, and our dynamic and it is a dynamo of our RSSDI Bihar chapter, Dr. Vijay Kumar. We are all honored by the presence of our patrons, distinguished faculty, panelists, members, students, guests who have joined us this evening. Our newly elected National North Zone member and keynote speaker, Professor Sanjay Vadada, could not be with us today due to some unforeseen reasons. After the encouraging success of first virtual meet of RSSDI Bihar chapter, we are delighted to bring you the second in the series, combining the didactic insights with the practical cases vignette for a complete and meaningful learning experience. Today's program, including a case presentation, interactive discussions, and a keynote on skeletal phase of diabetes, that is diabetic steatopathy, a concept that recalls, if you remember, the classic triopathy first described by Dr. Root in 1954, way back in 1954. Thank you all for joining us. Your presence and participation makes this academic evening truly special. Let us now begin the proceeding. Thank you.
So, thank you, sir. May I take this opportunity to invite our East Zone member-elect, Dr. B.K. Singh, sir, to address the gathering and for welcome address. Over to
Thank
Dr.
you.
B.K. Singh, sir.
Thank you, Dr. Vijay. First of all, I welcome Nathan, our chapter chairman, Supriya Mukherjee, chairman-elect, Dr. Shehwal Guha, and all the panelists, Dr. Manoj Indulkar, Dr. Lakhan Singh, Dr. Sanjeev Medhi, and Dr. Sandeep Mishra. And our learned speaker, Sanjay Kumar Vadada, though he is not joined yet, but he will join after some times. He is traveling to the Calcutta. And our case presenter, Dr. Ankit Akhil Mittal. So without further delay, because this program is meant for the students and the primary physician of the Bihar, Jharkhand, and all the East Zone member. So we have planned such a meeting that we can incorporate the total East Zone in one platform and discuss the further different topics like the case presentation and the discussion by some diabetic topic. So with this regard, I welcome on behalf of East Zone and on behalf of this Bihar chapter to all of you. And without further delay, I hand over the mic to the Dr. Vijay for further proceeding.
I'm very happy to note that RSSD Bihar is doing such wonderful CME programs for the students. I invited all of you to our flagship program, the RSDI annual conference, and Sanjeev Medhi has lined up a good program for RSD retreat. Looking forward to that also in Guwahati. And with these words, I hand over to Vijay Kumar sir, and I wish all the senior dignitaries who have assembled here, Supriya Mukherjee sir, and Sudhir Chandraja, and all the senior people who have contributed so much to RSD Bihar. Thank you very much.
Thank you, sir. Thank you for encouraging words. Actually, your words are very instrumental for us in organizing such CMEs and other academic and research activities under the umbrella of RSSDI Bihar. So thank you once again on behalf of RSSDI Bihar team for joining the CME and encouraging us with your words. Thank you, sir. So now we should proceed. We are proceeding to session 1. Session 1 is a case presentation by a postgraduate resident, and his mentor, Dr. Atul Baid, is chairperson of this session. So I would like to invite our chairman-elect, Dr. Sehwal Guha sir, and Dr. Professor Atul Baid for chairing this session. And panelists of this session, we are supposed to invite the panelists, Professor Manoj Indurkar and Professor Lakhan Singh. So over to Sehwal Guha sir for conducting this session and inviting the panelists.
Thank you, Vijay. Good evening, everybody. I would like to welcome Dr. Atul Baid, my co-chairperson, and the respected panelists for this session, Dr. Manoj Indurkar and Dr. Lakhan Singh, to the panel. And
Thank you, sir.
I would invite our speaker, Dr. Akhil Mittal, to start his deliberation.
Yes.
Dr. Akhil, the podium is yours.
Good evening, everybody, respected chairpersons and the panelists, and all the seniors and colleagues. With kind permission of chairpersons, I would like to start my case presentation.
Yes, please.
I'll be presenting a case of a 62-year-old female, Mrs. XYZ, who is housewife by occupation and of Kishanganj, Bihar. With a chief.
Can you share your screen? If it is a PowerPoint, better you share your screen so that it is visible for all of us.
Sir, it's not a
PowerPoint, sir.
PowerPoint. Sir.
It's not a PowerPoint, sir.
Okay, anyway, please go ahead.
Please continue. Please continue.
Please go ahead.
So I'll be presenting a case of a 62-year-old female, Mrs. XYZ, who is housewife by occupation and resident of Kishanganj, Bihar. She comes with a chief complaint of drooping right eyelid since 5 days. History of presenting illness. The patient was apparently asymptomatic, performing daily routine activities when she developed drooping of right eye since 5 days, which was sudden in onset with gradual progression. Patient also developed double vision since 5 days, and on further history of double vision, patient said that the objects were placed next to each other, which resolved on closing one eye and worsened on looking left in right eye and looking towards near objects. There is no history of fever, chills, rigor, or neck stiffness. There is no history of headache, vomiting, seizures, or altered sensorium. No history of ear discharge, sinus infection, or any focal neurological deficit observed. There is no history of swelling around ear or granulation tissue in ear canal. No history of nasal blockage, blackish nasal discharge, or facial swelling. There is no history of diurnal variation or fatigability. There is no history of periorbital or retroorbital pain preceding diplopia. There is no history of tingling, numbness, burning, or pins and needle sensation in the feet and hands, or any decreased sensation to touch pain or temperature, or any non-healing ulcers observed or unnoticed injuries observed. There is no history of postural dizziness, palpitations, syncope, no history of diarrhea, constipation, vomiting, or any history of UTI. There is no history of exertional chest pain, breathlessness, palpitations, orthopnea, or PND. There is no history of intermittent claudication or rest pain in feet, or any non-healing ulcers or gangrene. There is no history of swelling of feet, puffiness of face, or decreased urine output. And there is no history of blurring of vision, floaters, black spots, or sudden painless loss of vision. The past history of the patient. The patient is a known case of diabetes mellitus from past 15 years on irregular medications. There is no history of hypertension, IHD, stroke, thyroid disorder, or tuberculosis. There is no past surgical history. Personal history of the patient. The diet is mixed and irregular with normal sleep. There is no history of alcohol, smoking, or tobacco use in the past. Family history. There is no history of similar complaints in family. Drug history. The patient is on tablet metformin 500 irregularly as she lives alone. Proceeding to general physical examination. The patient is conscious, cooperative, and oriented to time, place, and person with average build and moderate nutrition. The BP in supine position is 120/80, and in standing position, it's 110/70. The pulse of the patient is 84 beats per minute. regular, normovolumic, normal in character, with no radioradial or radiofemoral delay, with all peripheral pulses felt normal. The temperature, the patient is normal. The SpO2 is 98% on room air. The pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema are absent. My patient has BMI of 30 kg per meter square with waist circumference of 92 centimeters and waist hip ratio of 0.92. And the ankle brachial pressure index of 1. Proceeding to the neurological examination. In higher mental functions, the patient is conscious, alert, oriented to time, place, and person. The digit span forward and backward is normal. Immediate, recent, remote memory tested and within normal limits. The MMSE score is 30 by 30. On cranial nerve examination, on examination of third, fourth, and sixth cranial nerve, there is right-sided third nerve palsy present. The eyeball deviated down and out with limitation of adduction and elevation. The abduction is preserved. The diplopia is present in left gaze. The pupil size is normal with normal light reflex. There is no proptosis or conjunctival congestion. Left eye movements are normal, and the other cranial nerves 1, 2, 5, 7, and 12 are normal. Motor system examination. The bulk, tone, and power of the patient is normal. No involuntary movements observed. Sensory system examination. Superficial sensations like touch, pain, and temperature are intact. Deep sensations like vibration and joint position sense normal. Monofilament test within normal limits. All the reflexes are within normal limits. Coordination of the patient, the finger, toes, dysmetria or dysdiadokinesia. The gait of the patient is normal. And other system examination, all systemic or other examinations are within normal limits. Summary of the case. A 62-year-old female with long-standing, poorly controlled type 2 diabetes mellitus presented with unilateral ptosis and diplopia. On examination, she had complete ptosis and pupillary reaction was spared. There was no other cranial nerve involvement or neurological deficit. Neuroimaging ruled out compressive or aneurysmal causes. So a diagnosis of diabetic ischemic third nerve palsy was made. Likely diabetic cranial mononeuropathy. On investigation of blood glucose, fasting sugar level was 150. The postprandial was 220 milligram per deciliter and the HbA1c was 9. The complete hemogram, renal, and liver function test all within normal limits with deranged lipid profile with serum LDL 130 mg per deciliter and serum triglycerides 220 mg per deciliter with MRI brain and orbit. With MRI brain and orbit, no abnormality observed, and the ECG and 2D echo within normal limits. The management plan. First of all, glycemic control was done with tablet metformin and glimepiride combination as the cost was an issue for the patient, and as it is a self-limiting disease and early glycemic control required.
No, Akhil, you wait. Akhil, you wait. That's the presentation. Let's now come to the discussion. Vijay sir and Shival sir, please, if you can give your inputs. That's regarding the case of the student.
I think Sehwal sir should lead. Sehwal sir.
Yes.
Vijay sir, you are muted, sir.
It's a classical case of ptosis due to third nerve palsy.
Yes.
It's a classical case where you have to control the hyperglycemia, which is rampant in many of the Indian patients, and you should start her on insulin to control the fasting and the BP, and tell her that you can take off insulin once the eyeball starts moving. Thank you, Dr. Abhijit. No, I didn't get your name.
Akhil, Dr. Akhil Mittal. The presenter's name.
Akhil.
Dr. Akhil Mittal.
Akhil.
Mittal.
Good presentation.
Thank you, sir.
Shall we consult our panelists now, Dr. Manoj and Dr. Lakan? Dr. Manoj first, are you there?
He presented very nicely, sir. one thing during examination, whether he examine all the cranial nerves properly, and apart from that, whether he examine vestibular ocular reflex, saccadic movements, that is very important. And very importantly, there is a sparing of pupillary reaction, which usually seen in diabetic patient. Many times we go for the MRI very fast. First, we wait for at least 1 week, and then we must go. Because if it is complete, mostly it is because of diabetes. But if it is partial and it is a progressive, so it may be possible, it may be because of some aneurysm, or it may be because of some infection, demyelination. All this cause may lead to the progressive. So it is if we classify it, it is a acquired non-traumatic palsy. So examination is very important, whether it is complete or incomplete, or it is just partial. So he nicely presented, and definitely we have to rule out other causes in such cases. So MRI is mandatory, but it is usually in diabetic patient, you must go for after a weeks. In the first week, the chances, if it is complete, the chances this is isolated and because of the diabetes. So,
Dr. Vijay sir, can I speak a few words,
Sure,
if
sure,
with your
please.
permission?
Please.
Shabil sir, can I speak? So good evening, everybody. So thank you for joining in. So Dr. Akhil is my first year resident here in Mata Gujri Memorial Medical College. So the idea of presenting this case was diabetic cranial mononeuropathy. So in the course of presenting this, these students, they get to learn the whole classification and the pathogenesis of diabetic neuropathy. One. And second, when we discussed this in the department, we emphasized the diabetic cranial mononeuropathy, since it is a microangiopathic infarction. So it can be a marker for loss of vascular integrity in other systems also. These patients should be very aggressively screened for other microvascular complications like nephropathy and retinopathy, one. And two, these patients should be subjected to very aggressive lifestyle management and oral and the glycemic control. Akhil, may I ask you, is there any pharmacological treatment for this diabetic neuropathy, cranial mononeuropathy, third nerve palsy?
Sir, as such, it's a self-limiting disease.
Okay.
There is no treatment available. The corticosteroids can be used, but it can impair the glycemic control of the patient.
Okay.
So we can go for pentoxifylline use, but its use in these conditions is limited. The study relevant to this is limited, but it can improve the blood supply through vasa vasorum, so it can benefit the patient.
All right. So there is limited evidence for pentoxifylline, but it does. The studies which are available are on the rats basically, but logically it appears attractive because it can alter the rheological properties of RBCs. All right.
Dr. Lakhan Singh sir, I would like to have your opinion on this.
Yes, sir. Yes, sir. Good evening to nicely presented by the Dr. Akhil, and one of the very interesting case. And although yes, rightly said that I fully agree with Dr. Atul and Dr. Indurkar sir, that is one of this cranial nerve is very common. Some of the clinical examination, yes, something missing. What about the speech and other indirectly it is a cranial nerves, fully cranial nerves examination is mandatory for, because yes, this is because of the microangiopathy, and now that this early stage of we can say that is microangiopathy may lead to mononeuropathy, multiplex, or any other involvement can be, or we can see other things like other signs of the microangiopathy or involvement of the other. Also, we can't forget about the other involvement like autoimmune disease, and this should also look into this kind of the suppose patient presented with the mononeuropathy, especially in diabetic. Of course, it may sometimes it's common. Sometimes it may presented with the only third cranial nerves, may sometimes associated with the fourth and sixth also noted. And Dr. Atul is rightly said that this is self-limiting. self-limiting, and it take time 4 to 6 a week at least. If we go for the good control of the blood sugar, I think once as per literature, if it is in microangiopathy started, early changes came in the fundus as well as the microalbuminuria. So always this kind of the patient should put on supportive add-on of the insulin along with the OHA, as per my opinion. So
Okay, sir.
But Akhil, why neuropathy, why peripheral neuropathy is not there?
yes,
So as there is no history of tingling, numbness, or burning or pinch sensation in the hands and feet of the patient, there was no history of decreased sensation to touch, pain, or temperature. So it rules out the diabetic peripheral neuropathy, sir.
No, why is it not there? It is not
Because
there. Usually the company's third nerve also, peripheral neuropathy. Peripheral neuropathy occurs in impaired glucose tolerance.
So, Akhil, did you do a monofilament test in this patient?
yes, sir, the monofilament test is wrong, sir. It
So
was
you can say there is no clinical evidence right now, but you would like to do a biothesiometry and nerve conduction velocity and CV also in this patient. So there can be subclinical neuropathy. Sir, am I right, sir?
Yeah.
yes.
And we can also test the small fiber neuropathy with temperature.
Yes.
yes, sir.
Can I come
That
in,
is
sir?
so. Yes.
So there was no history of, there was no decreased sensation to touch and pain and temperature. We did the
That's fine. That's fine. So you already said that. Sir is
Yes.
asking why peripheral neuropathy is not there, because usually that concomitantly exists with diabetic cranial neuropathy. So you would like to subject her to investigations, mainly biothesiometry and other investigations, no?
Yeah.
Okay.
Can I say something, sir?
Sir, please.
Sure.
So this is a classical case of diabetes, mismanaged diabetes leading to microvascular complication. And we all know that the microvascular complication neuropathy is one of the most commonest complications which every diabetic comes across. Now, if you see the microvascular complications, it can be either a cranial mononeuropathy, then can be neuropathy in the other parts of the body also. And what Vijay Viswanathan sir was rightly saying, that this bilateral polysymmetrical polyneuropathy is the commonest. That is the commonest which every diabetic faces. So that can be there in this patient also, and it may not be there, but usually this coexist. If the person has got oculomotor cranial neuropathy, then most likely he or she will be having a this proximal or this distal symmetrical polyneuropathy, which is the classical form of diabetic polyneuropathy. Now, the most important point is the oculomotor nerve palsy, which this patient is having. Now, if you see the causes of, diabetes is the cause of exclusion. We can't, because only she is diabetes, we can't take it that she's having, that the cause can be because of diabetes only. That is a diagnosis of exclusion. After you have excluded all the causes of oculomotor palsy, then you can say, yes, this cause is because of diabetes. So what needs to be done is that we need to rule out other causes of oculomotor nerve palsy. And if you see, the oculomotor nerve is innervated both by this pupil is being innervated both by the sympathetic and the parasympathetic nerve. Now, oculomotor carries the parasympathetic segment of the innervation. So, this pupillary sparing carries a lot of meaning, actually. So, you must always check the pupillary light reflex if you need to exclude something. Because if you see the oculomotor nerve, the pupillary nerves are usually placed in the periphery of the oculomotor nerve. So if the oculomotor nerve palsy is because of some external pressure, it can be because of tumor, it can be because of aneurysm, it can be because of some trauma, or it can be because of some any other external cause, then the pupils will be involved first. And if the cause is inside the oculomotor nerve, as it occurs in a diabetic case, because it is ischemic, so the cause is inside the nerve, so the pupils will be spared. So here lies the importance of whether the pupil is spared or the pupil is involved. If the pupil is involved, then you must always think for some aneurysm, some tumor, some other cause which is causing an external compression, some after some surgery and all. But if the pupil is spared, that means the cause is inside the nerve. So this is the importance of having of taking the pupillary light reflex. It gives us a lot of meaning. It carries a lot of meaning. What is the cause of this oculomotor palsy? I hope I'm clear. I just wanted to make this.
Yes.
Yeah. Thanks, Dr. Mehdi. That was
Thank
a
you,
great input. Any other comments from anybody else in the audience?
Dr. Sudhir Chand Nasser, would you like to give your input? Dr. Jha, sir.
Yes, this is a very interesting case, and involvement of non-involvement of pupillary, it is a very good prognostic marker. First. Second, before embarking on anything, as Dr. Medhi has rightly pointed out, and contrast enhanced MRI will settle the issue whether any cranial aneurysm or any space occupying problem pressing on the nerve is there or not. Thirdly, if a cranial nerve mononeuropathy is there, then it is very important, urgent to go for other forms of neuropathy, because it is a mismanaged case of this diabetes mellitus. And as far as the treatment part is concerned, intense control of sugar. If I remember correctly, he said that glycosylated hemoglobin is 9. So by insulin and maybe combining with other drugs, it has to be brought down to the lower level as much as possible. This is the thing. This is a very interesting case.
Thank you, sir.
Thank you,
Just
sir.
like to add, Dr. Guha, just like to add that in the coming on that this diabetic neuropathy involvement of the oculomotor nerve, but it is because of diabetes is the commonest cause of oculomotor palsy.
Yes.
Then almost is considering almost 50% of the cases occur because of diabetes. But if you see the treatment part, then of course what Dr. Viswanathan has said, that these patients should not be given any OHs. They need to be given insulins. First of all, for the glycemic control, for improving the internal milieu of the body, which is very important for any nerve regeneration to occur. The internal milieu, all the internal toxicity which is there, the inflammation which is there, can be taken care of by insulin only. So it will not be nice if we prescribe these patients OHs. They need to be given insulin till the time they recover, and once they recover, then you can of course switch them on to OHs again.
Yes, glycemic toxicity need to be controlled by insulin alone in any cases, anywhere in diabetes.
Yes, sir. One point is I just wanted to say that if any patient is supposed, we can't concentrate only their neuropathy. We should always look for the other nephropathy or retinopathy, or we should look other complication or macro or micro angiopathy like that.
This is very important, as Dr. Lakhan
Yes.
Singh has pointed out, because even at the time of diagnosis of type 2 diabetes mellitus, many of the cases are already having neuropathy, and some of them are having this nephropathy as well. So exploring other complications is of paramount importance. We should remember that whenever a diagnosis of type 2 diabetes mellitus is done, already 50% of the beta cells are gone. And in most of the cases, some complication or other are there. Clinically, we cannot ascertain that. We have to go for the investigations.
And if you see the management part again, I think all the three aspects, be it the blood sugar, be it the pressure, be it the lipids, and some vitamins, needs to, as the Steno trial has clearly said, that a holistic approach, so good control of BP, good control of sugar and the lipids. Because after all, it's endothelial dysfunction, which is the root cause of all this this microangiopathy. So for that, we need to control the lipids, the pressure, and of course the sugar.
Yes, beyond doubt.
So with due permission, Dr. Manish, would you like to add anything?
Thanks a lot for, yeah. Thanks a lot for the valuable inputs from all the dignitaries. Anybody else who wants to share his expert opinion on this?
Dr. Manish, would you like to add anything? Dr. Manish Prasad.
Yes, really it was a very interesting case, though there was some finding which was really untouched because there was
Just a moment, Manish. Sorry to interrupt you. Sorry, Dr. Vishwanathan sir wants to leave. So I would like to thank him on behalf of the Bihar chapter for taking time out to join today, sir, and stimulating us in this academic endeavor. Thanks
Yes,
a lot
your
for your
presence
presence,
was very
sir.
inspiring.
Thanks a lot for your presence, sir.
I wish
And
you all
we
the
expect
best.
to have you in future again.
I wish you all the best. And RSD Bihar is doing a fantastic job.
Thank you, sir. Thank you so much.
Thank you, sir.
Over to you, Manish, please. Sorry if I interrupted.
Thank you, sir.
Please carry on,
Really, it
Manish.
was a very interesting case presented by a lovely PG. I must say one thing. It should be presented in a PowerPoint presentation. There was few findings which we could not adjust. Although the treatment was great, I must say we have to go ahead for the next session. Thank you.
So,
yes, over to you, Vijay.
Thank you, sir. Thank you, our chairpersons, our panelists for conducting a session and making it so much interactive. And the case was very interesting, and I think a lot of discussion has been done on the case. So moving to session 2, actually it was to be done by our senior member, Dr. Professor Sanjay Bhatt, Head Department of Endocrinology, Chandigarh. But sir is traveling, sir is on board, and as soon as sir lands, so he will join. But in the meantime, we have a recorded session. Sir has sent a recorded session. At the time of interaction, sir will join definitely. So to conduct this session, I would like to chairperson of this session, Dr. Supriyo Mukherjee sir, our chapter chairman, and Dr. Subhash Kumar sir, our chapter vice chairman. And panelists of the session are Dr. Sanjeev Medhi sir. He is Chief Consultant at Pratyasha Healthcare, Guwahati, and Chairman-elect Assam chapter, and Dr. Sandeep Mishra from Cuttack. He is the chapter treasurer of RSSDI Odisha chapter. So over to Supriyo sir. And Subhash sir. Please unmute, sir. Both of you, please unmute and conduct the session. Mr. Anand, to facilitate the recorded version of Professor Bhadana sir presentation. Anand ji.
Supriya sir, good evening, everyone. Supriya sir, kindly unmute the.
Just wait, Anand ji, just wait. Let chairperson invite the panelists first.
Supriya sir, we cannot hear you. Good evening, everyone.
Hello.
Yeah, yes.
I'm audible now?
Yes, somewhat.
And now?
Can you increase the volume or something, sir?
Sir, you are both audible and visible.
You are audible, sir. You can carry forward.
I don't know what happens.
Sir, you are audible, sir. Please go ahead, sir.
Okay. Thank you, Dr. Vijay. It's privilege. Let me introduce in absence here Dr. Professor Sanjay Kumar Vadada. And before that, let me welcome our co-chair, Dr. Subhash Kumar, our chapter vice chair, and Dr. Sanjeev Medhi, our panelist, our esteemed panelist, and Dr. Sanjeev D. Mishra, our panelist. And second job to introduce Professor Sanjay Kumar Vadada, Head of Endocrinology, PGI Chandigarh, a distinguished clinician scientist whose work has greatly advanced our understanding of bone and mineral disorders in endocrine diseases. His research highlights how diabetes quietly weakens the skeleton. Just beforehand, we were listening to macroangiopathy, neuropathy, and that. There's the same way the bones are involved, how bones are weakened, positioning bone as a fourth target organ of hyperglycemia, giving rise to concept of diabetic nephropathy, the skeletal face of diabetes. Though Professor Badada could not join us today, we are delighted to share his pre-recorded lecture on diabetic nephropathy, how hyperglycemia hurts the skeleton. Over to Dr. Vijay. Please do the recording. Please play the recording.
Yes, sir. So, Mr. Anandji, to facilitate the recorded version, and as soon as Badara sir will lands at Calcutta, he will certainly join for discussion and interaction.
Yeah, very good evening. And at the outset, I would like to thank RSSDI Bihar chapter for giving me this opportunity to talk on this important topic, that how hyperglycemia hurts or harms the skeleton or the bone. Sorry, I could not make personally here because of some personal commitment on this particular day, and I was supposed to be online, but there is some emergency meeting at Calcutta. I have to travel, so I'll be taking your question answer session at the end of the conference, but you can always send me your question answer session. So coming to the topic, that bone health in diabetes, can we call this diabetic tetraopathy or osteopathy? Is a question to all the audience. Now I'll cover in next 15 minutes following topics. Does diabetes affects the bone health? Why bone health is poor in diabetes? What is the pathogenesis? And what anti-osteoporotic medication is ideal or preferred in patient of type 2 diabetes with osteoporosis? And how anti-diabetic agents affects the bone health? We all know that diabetes is associated with micro and macrovascular complications. In microvascular complications, diabetes affects the kidney, retina, nerves, that we call it as a triopathy. Does diabetes affects the bone, and can we call it as a tetraopathy? And we know that skeleton is responsible for 10% of the cardiac output, and glucose is essential for effective work done by the cells, and the vasculature of bone is like microvessels. So bone actually qualify for a microvascular complication, and so we can call it as a, instead of calling triopathy, we can think about the diabetic tetraopathy. So how diabetes or hyperglycemia actually degrades the bone, and indeed it degrades every compartment of the bone. In this particular cartoon, which is an interesting publication for Endocrine Connection 2019, on one side you see there is a bones are healthy, on other side bones are unhealthy, or the patients of type 2 diabetes. So you see that on the healthy side, we start from one by one. You see the cellular component. So you see first of all osteoblasts. So osteoblast number in healthy individual is much larger as compared to patient with type 2 diabetes. Then coming to the osteoclasts, maybe the osteoclast number is same in both compartment, healthy as well as type 2 diabetes. While in case of osteocytes, you can clearly see that osteocyte number as well as connectivity of osteocyte is reduced in the patients of type 2 diabetes, and we all know that osteocytes are indeed pituitary of the bone. Now coming to the bone marrow, and you can see that bone marrow is having lot of fat in patient of type 2 diabetes as compared to healthy individual. Then you are coming further down and you see that there is advanced glycation end products are deposited in the diabetes individuals compared to the non-diabetic. Then you look at the cortical porosity, which is increased in the patients of type 2 diabetes as compared to healthy individual. And coming to the blood vessels, the blood vessels are also affected and blood supply is poor in patients of type 2 diabetes as compared to the healthy individuals. Then you look at the risk of fall. The risk of fall and fracture is also increased in patients of type 2 diabetes. So there is multiple mechanism by which hyperglycemia affects the bone health poorly, or you can say the hyperglycemia harms the bone in bad way. Now coming to the what literature says is that there is an interesting meta-analysis which was published in 2007, way back long, and you see that in patients of type 2 diabetes there is increased risk of fracture by 1.7 times, and in the type 1 diabetes the situation is even worse, that risk of fracture is approximately 6.3 times of the risk of fracture is increased in type 1 diabetes. You might be wondering that in India we are not seeing these patients of type 1 diabetes with fracture. Yes, the reason is very clear, because in India the mean survival in patients of type 1 diabetes is very less, maybe 30 to 35 years. That's why the patients are having the maybe poor bone health, but they are losing their life because of the CKD before the patients are developing the fractures. Now I take you through the interesting publication which was done at our institute from the 3 cities in and around Chandigarh, and in this particular study we collected the data of 264 patients with hip fragility fracture, and these patients were followed up for the 1 year at 3 monthly interval. And this study was actually eye-opening for us. In this particular study we observed that at the end of 12 months, nearly 21.5% of patients are losing their life. And what we found is that diabetes was an independent predictor of the mortality in these patients with the hip fragility fracture. Now you look at the diabetes phenotype in Indian patients, and you see that Indian patients having onset of diabetes, it is younger age. They have more central obesity, so they have more hyperinsulinemia or insulin resistance, and there is high inflammatory markers. Because of high inflammatory markers, more central obesity and higher insulin resistance, there is more bone damage is there. And since the diabetes developed the younger age, so because of the chronic illness, the peak bone mass is not achieved. That will also affect the peak bone mass at younger onset of diabetes. All these 3 phenomena ultimately lead to the diabetic bone disease, and it will further actually contributed by the high prevalence of vitamin D deficiency and early age at the menopause. In another study, we tried to look in the patients of type 2 diabetes that what are the risk factor for developing the poor bone health or the osteoporosis in these patients. And what we found is that female gender, increasing age, low BMI, vitamin D deficiency and use of pioglitazone were associated with increased risk of osteoporosis. Now I take you through a very interesting study which was done in collaboration with the IIT Ropar, and my close friend and collaborator Dr. Naveen Kumar, actually in his lab this study was conducted. The human samples were provided from the PGI Chandigarh. So in this particular study what we did is that we collected the patients, selected the patient, those are having hip fragility fracture. 40 patients with non-diabetes hip fragility fracture, 30 patients with diabetes with hip fragility fracture. And we compare their baseline data, and you can see that there was no significant difference in any of these parameters, whether it is the age, whether it is the duration of diabetes, whether it is serum calcium, serum phosphorus, PTH, vitamin D, alkaline phosphorus, all were comparable. And look at this, even the bone mineral density, that is the aerial bone mineral density, was also comparable in these 2 groups. So what we did is we collected the head of the femur from these patients because they underwent the hip replacement. So it is known that during the hip replacement, they take out the head of the femur and generally discard it. So we collected these head of the femur from all these patients, and we did the microstructural analysis with the micro CT. And you can observe very clearly that no need to go into the detail of the numerical values. You just see that in patients who are non-diabetics, the bones are more thicker and well connected as compared to the patient with the diabetes. Then we did their composition analysis, and in composition analysis we look at the mineral to matrix ratio, and what we found is patients of non-diabetic individuals are having better mineral to matrix ratio as compared to the patient with the diabetes. Further, we did the nano indentation, and in nano indentation, simpler word I'll say that is the malleability of the bone, how much bone is malleable. So in patients of type 2 diabetes, our bone is less malleable or less modulable, meaning by that if there is any stress, the bone may fracture instead of bone is malleable. If this bone is malleable, then the chances of fracture are less. So you see here in patients of non-diabetics, bone modulus is better, meaning by that bone is more malleable as compared to patient with the type 2 diabetes. And also looked at the hardness, and you can see the hardness is better in non-diabetic individuals compared to the diabetic individuals. So patients with type 2 diabetes actually having the poor modulus and the less hardness, these two important properties actually predisposes the individuals of type 2 diabetes for the fracture. So this was done with the trabecular bone. Then now we did with the cortical bone. We did the cortical bone microstructure analysis also. And here what we found is that cortical porosity was much higher as compared to the non-diabetic individuals. And then mean canal diameter was also higher in the patients of diabetes as compared to non-diabetic, and all these predisposes for the fracture. Further, we went on, and what we did an interesting work which was published in scientific report. And here what we did is we collected the patient's nail, and that is of the healthy individuals, patient of diabetes with good blood glucose control, and patient with diabetes with poor blood glucose control. And what we study their structural properties, their surface properties, and their biochemical properties and mechanical properties. I'll not go into much detail, but just draw your attention on these three pictures. Those are given here in the, so you see that structural properties, born in type 1 diabetes, born with the diabetes with uncontrolled blood glucose, there is poor surface structure is there. And you see here that surface properties are much worse in patient of uncontrolled diabetes compared to the healthy and the diabetes control. And you must have observed in your clinical practice that patient of type 2 diabetes having the fragile nails, the brittle nails. These brittle nails are because of the hyperglycemia. And further what we did is we selected the patient, we were having the and collected the nail as well as the bone, and we compare, and what we found is a very great correlation between diabetic and non-diabetic individuals with relation to sugar to matrix ratio and relative CML content. There was a very good relationship. Now coming to the treatment, so if you see a patient of type 2 diabetes with osteoporosis, what should be the ideal treatment? And we know that three major treatments are available. One is bisphosphonates, second is the denosumab, and third is the teriparatide, that is recombinant PTH. So we planned this study, and here is a brief protocol of this study, and my colleague Dr. Ramesh does this study in our department, and Dr. Trupti was his thesis was there, her thesis was there. And this particular study, we divided the patient to 4 groups. One is teriparatide, second group received zoledronate, third group the denosumab 6 monthly, and the fourth was a control group. And at the analysis, what we did is that we assessed at the 72 week, at the end of the 72 week, we did their bone mineral density, high resolution peripheral QCT. High resolution peripheral QCT actually gives a kind of information like a bone biopsy. And we also assessed their safety analysis, looked for the fracture and the various other parameters. So in this particular study, what we found is the baseline parameters were comparable among the all four groups. And you see that P1NP level was elevated with the teriparatide as compared to the CTX, and it was much better as compared to the other group. And that is forming a anabolic window, meaning by that during this period the bone formation will, and that will continue even at the end of the 72 weeks. Now look at the lumbar spine and femoral neck bone mineral density is a primary endpoint of this study, and what we found is that teriparatide, that is recombinant PTH, did the best, because at the lumbar spine they increased the bone mineral density by 11.3% as compared to the nearly 4% with joledronate and the denosumab, while the control patient lose the BMD by 1.7%. Even at the femoral neck, teriparatide showed the great effect, and they showed rise in bone mineral density by 3.8%. Joledronate and denosumab are able to increase the bone mineral density by 4 to 5%. And all these results
और ये
were
मछली है यार, अरे मछली तो कांटा निकाल कर खाई कर ले
you can use any of these drugs for the
पहले कनी उठा के देखियो नहीं बढ़िया रखो ना रखो
osteoporosis in type
हां
2
कनी
diabetes.
उठा पड़ता
The
हां
best
कनी
is
उठा पड़ता
Please mute.
teriparatide at the spine
बहुत अच्छा है खा
and
ले
the
अरे
joledronate
बड़का
at
बड़का होटल में ये मछली घटी छे
the neck BMD. Looking at the
पूरा खाओ
fracture
ये
rate,
पूरा खाओ
so none of the patient on
नाश्ता
the
करके
treatment group developed the fracture, while in the control group
अच्छा सुना मछली से
there was 2 incidental fractures were
अच्छा
there,
सामान खा कर
and those are clinical major osteoporotic fractures were there, and 2 patients had the distal radius fracture. Now coming to the secondary endpoint with relation to the high resolution peripheral CT, it gives the
हमने दो
information of
तो
60
बिना बालिक हो
micron thickness,
ये सब
and
तुम्हारा
what
बालिक
we
तो
found is
बिना
that
बालिक हो
cortical porosity is in patients of the control group is increased, while in patients of the teriparatide the cortical porosity is much less and messes. So best is to improve the cortical porosity is the teriparatide, while the poor with the control they increase the cortical porosity. Another second point with relation to it was the previous slide was with the tibia, and here is the with radius, and again showing the similar result that cortical porosity is increased maximum in the control group, and the least benefit was and the best benefit with the teriparatide. Similarly, the trabecular thickness was much better with the teriparatide as compared to the control, as well as joledronate and the denosumab. So we also looked in this particular study that is there any effect on the fall in patients with those are receiving anti-osteoporotic therapy, and what we found is that compared to control there was less fall as compared to patient those are receiving the anti-osteoporosis treatment. Now we know that a lot of anti-diabetic agents are used, and those are also having the effect on the bone health. So among 2 drugs are notorious. One is the gliflozins, and the second is the maybe semaglutide or the anti-obesity medication or the GLP-1 receptor agonist. So this interesting publication on the volumetric BMD and bone microarchitecture with the effect of semaglutide, what we have studied and what we found is that semaglutide is safe to use in the patients of the type 2 diabetes. There is no deterioration in the bone mineral in the volumetric BMD, rather than there is increase in the volumetric BMD with that. Because of the scarcity of time, I am now showing the data with the gliflozins. We did the similar type of study with the dapagliflozin, and we found that dapagliflozin is also not deteriorating the bone health, though it in some of the earlier studies, canvas, that is shown that there is problem with the increase the foot diabetic foot amputation, but with dapagliflozin it was not shown. So I end my presentation by your patient listening, and I can say the bone is also considered a microvascular complication, and if there is any question or comment, I'll be happy to answer on the email. And I say finally that skeleton should be considered a target end organ for diabetes, and it needs extensive research to prevent the fractures. Thank you very much once again for patience listening. Thank you RSSDI Bihar for this opportunity, especially Dr. Vijay Kumar. Thank you. Bye-bye.
So
Thank you,
over
Sanjay.
to you, chairperson, for inviting the panelists for discussion. And if any question is there, we can put in chat box. We will address one by one.
Yeah. Thank you, Sanjay Badara, sir, for such a nice presentation. Actually, I missed your talk during IdeaCon, but I got the opportunity to have it here. So to start the discussion, actually, most of the physicians they are giving less time to examine the patients properly. So that's why they are missing the bone health. By simply examining the nail level, what sir has already told, simply examining the nail and the nail structure, nail condition, one can guess about the bone, diabetic osteopathy at the earliest. So thorough examination of patient is primordial for all the diabetic patients to be conducted at each visit, and then only we can go for any sort of investigations or. And another thing I want to say, actually, bone health is more related to quality than the density. So in diabetics, bone quality is deteriorated, even though the density is showing normal. So we have to check thoroughly for everything so that our patients won't land up in any sort of osteopathy, like the dreaded one is the sarcoarthropathy. Even though sarcoarthropathy is there, but still other bony deformities are also there, or bony bone health is deteriorated, like diffuse idiopathic skeletal hyperostosis and osteoarthritis. Also, it is one of the causes diabetes, and chiroarthropathy is also there. Over to you, sir.
Over to our chairpersons for inviting other panelists for his input. Subhash sir and Supriya sir. Subhash sir.
Supriya sir is talking something. I think we can we? I am not able to hear him. Sir, voice I'm not getting. Is it with everybody or only I am not able to hear him?
No, we are also not hearing it.
We are not hearing.
Now, Supriya sir is the most of the time inaudible.
Are you hearing? And now?
Yeah. Now you're audible. Now you're audible.
I'm not. I don't understand.
Again, it became unaudible.
Please carry on, Subhash sir. So there is some technical.
Sir, you can mute the video so that audio can be better. If at all, because of the net.
Audible or not?
Yes, audible, sir.
Yes, now it's audible.
Because I was talking, I don't know what is happening with me, but it was a very excellent and enriching presentation. I personally learned a lot. But the point is, the one thing which I wanted to ask if from Dr. Vadeda, as in practical terms, when and how should we clinician start to screen the skeletal involvement? That is what always and how to rather go with that. That is important for us clinicians to go with the basic and to the maximum. How we start, where to start, and what are the indications to go for the investigations and all. This is my question to Dr. Vadeda.
I think Mehdi sir will answer. Mehdi sir.
See, actually, if you see the skeletal involvement in diabetes, it's very rampant. Every patient with diabetes has got some or the other skeletal involvement. More so in the females. More so in the Indian. Every female diabetic who come to us, either they have got a hip pain or there's knee pain, some form of osteoarthropathy or any skeletal involvement is always there in a patient, but we always miss it because we always see the other micro and the microvascular complications, and we take that yes, this will be there. But that is not a thing because, as Dr. Vadra has told, that a fracture risk is dramatically increased in every diabetic patients. But the point to be remembered is the cause of the skeletal involvement is different in both type 1 and type 2. In type 1, the peak bone mass is less because the disease process starts early in the body. So the insulin-like growth factor is also less in type 1 diabetes. And because the insulin-like growth factor is less, definitely the skeletal mass, the peak skeletal mass will be less. Whereas in type 2 diabetes, the cause is different. Here it occurs after the patient attains the skeletal mass. So it is the advanced glycation end product leading to the deform in the collagen and all these factors, increase osteoblastic, more of osteoclastic and more of osteoblastic activity, less of osteoblastic activity, which causes the increased risk of this fracture. Another of the speaker has clearly told that we should not be foxed in any diabetic patient if you get a good BMD report, because the bone may appear good, but quality is bad. So this is very foxing. You should not take a BNB report on a face value and say that, yes, your report is okay, your bones are healthy. No, that is not the case. The bone minerals may be okay, but the quality is poor because diabetes affects the collagen. And then these collagens are affected because of the advanced glycation end product, which occurs in every diabetic patient. And this non-enzymatic collagen, this non-enzymatic process by which the collagens are affected is the root cause for this poor bone health. So every diabetic patient needs to be evaluated for every skeletal involvement. And another practice which we all follow, just prescribing calcium, that is not a treatment. Because by prescribing calcium now, as it has come to the fore, that by giving unnecessary calcium, we're increasing the chance of the calcium score in the coronaries. So the unnecessary use of calcium needs to be curtailed, because just by giving calcium, you are not improving the bone health unless you are supplementing it with denosumab or this arendronate and all this, or this teripeptide and all. Along with that, you can give calcium to increase the osteoblastic activity, but calcium alone will not do much health unless will not do much good unless the patient is really calcium deficit. So these points have to be kept in mind when we treat a diabetes.
Dr. Mehdi, my question was very simple.
Yeah.
My question was when and how and what is the duration of the diabetes? There will be a specific point. What is the duration of diabetes? Is it really affects the bone health or not?
Yeah, that I have told. That I have told.
And let me finish. And,
Yeah.
and when to start clinical evaluation? From the very beginning, just like from the very beginning, we should have a core. So, but I think that at the very core of diabetes, when the person who is coming, there's a missed opportunity that we don't see our patient's bone health. With what I learned from this, what I have learned from this talk, that we rather miss our opportunities not to screen bones at the very outset when the patient comes to us, due to the reason behind us that the age of the patient, sex of the patient, the bone involvement, the quality, the quantity, and everything, and what are the important clinical tests which really will help us to land into the diagnosis that this patient is really needs terapeptide or some drug which is anti-resorptive. So this is basically what we wanted as a clinician to put our things into the clinical regimen. That is what I wanted to ask.
Okay. Now here it depends whether the patient is type 1 or type 2. If the patient is type 1, as I've already told, because the cause in type 1 is different for the bone involvement and the cause in type 2 is different for the bone involvement. So in type 1 patients, we need to evaluate them even at a younger age to see whether the skeletal mass is really involved, because it is the cause, as I've already told, the insulin-like growth factor is less in type 1 patients. So naturally the bones are involved earlier. But in type 2, the involvement will be in the later part. So again, it depends on the duration of the diabetes. So once the patient is diabetic for a longer duration of period, definitely his skeletal involvement will be much earlier. So type 1 patients needs to be evaluated little early in their, maybe in their 20s also, in their 20s, in their 30s. But a type 2 patients, of course, in 40s, 50s, depending on their age at which the diabetes occurred to them. Am I clear on this point?
Do you have some evidence behind this sentence that we should have a bone evaluation for type 1 diabetes at this age and type 2
No,
diabetes?
I can't quote any study for this, because, but this is just the physiology, it is just the physiological factor reason.
What is
which is-
presumed? What we
Yeah.
presume. Thank you very much. Thank you.
Dr. Bedi,
Yeah.
well explained the things. There are certain medications which cause more bone damage, and there are other medications which are supposed to be good for the bone health, like SGLT2 inhibitor and pioglitazone. They are detrimental to bone health to some extent. I don't know how much to extent, but they are considered that bone health is compromised in that. So should we switch over from this SGLT2 inhibitor and this pioglitazone to the molecules which favor good bone health, like GLP-1 receptor agonist and insulin?
It is a very
Sir,
good
you have
question.
asked a very good question. Sir, you have asked a very good question. Now, see, pioglitazone, every case has to be taken on a particular case-to-case basis. Now, a person who has got who is osteoporotic, have increased risk of fracture, a female basically, who's if you see the female, actually I'm not an endocrinologist, so I'll not be able to specify the exact, sorry, I'm not an orthopedician, so I'll not be able to specify the exact areas which needs to be screened. But the femoral neck is the most commonly involved in the females, plus the distal radius and the ulna are the most commonly affected areas. So any patient, any diabetic patients who has got an increased risk of fracture, definitely, and more so if she is a female, that to a post-menopausal, definitely I will not advise you to put her on pioglitazone. But again, if it's a male whom you want to give more of this protection from the cardiovascular and other microvascular complications, then pioglitazone is the better choice to prevent the other inflammatory markers, to improve the internal milieu of the body. If you really want to see from that point of angle, then definitely pioglitazone has to be given in those patients. But in a female who is postmenopausal, who is osteoporotic bones, chances of fracture is high, definitely pioglitazone needs to be avoided.
Now, a very popular question which comes to our mind: where does vitamin D stand as far as the bone health is considered? Since 70 to 80% of Indian patients are vitamin D deficient, and more so diabetic patients. Most of our patients are vitamin D deficient. So I want to know, where does vitamin D stand in the management of the osteopathy caused by diabetes mellitus?
Yeah, it has been seen that low vitamin is associated with increased risk of fracture, more risk of osteopathy and all this. So we need to have vitamins above at least 20 to 30. If it is above 20, well and good. If it is above 30, very good. But below 20, definitely you need to give go in for replacement. There is no doubt in it. But having between 20, 25, 30 is okay. But a good means at any point of time, you need to avoid the deficiency of vitamins, of this vitamin D. And we all know that vitamin D plays a very important part more in the osteoblastic activity of the bone. So if you really need to prop up the osteoblastosis of the bones, the vitamin D has to be there in the body in ample amount. So that has to be kept in mind, because the vitamin D deficiency, definitely chances of fractures will bound to be increased, and osteoblastic activity will increase, will decrease, and osteoclastic will increase. So that's the point.
There are articles suggesting that it should not be on the lower part of vitamin D because it has got a wide range, 29 nanogram to 75 nanogram.
Above 30 is okay. Above 30, nothing to be done. But if it is 20, kam chal jayega. But below 20, definitely you need to treat.
Okay.
Any other questions from our esteemed audience or our faculty? Any other questions? And Dr. Vijay, you have to put those questions to Dr. Vadeda to answer, because we have to write it and we have to send these questions to Dr. Vadeda also. He must, if
Yes,
he
sir,
is
but,
able to
but I
answer, then
think,
it would be fine.
but I think I don't need so, because Mehdi sir has filled the gap, and Mehdi sir is addressing all the questions and queries very well.
Now, regarding the treatment part, as Dr. Vadera has clearly told that teriparatide is the most efficient. But again, you have to use it for only 2 years.
Yeah.
Using it for more than 2 years, chances of sarcomas and all the risks increases. Same happens with zoledronic acid. Zoledronic acid has been seen to improve the bone density in the spine as well as the femoral head, and chances of fracture risk decreases drastically. So once a year injection of zoledronic does wonder, then just blindly giving calcium will not do any good unless you supplement it with zoledronic acid or teriparatide. And zoledronic acid, I find it more comfortable, and cost-wise also it is more better suited to the patient, because once a year the one injection costs around 3,200 or 3,300. You give it for 1 year, 2 year, and 3 year. After 3 year, you stop it. Don't give it for. Don't keep on giving it for continuously 4-5 years, because it has been seen that more use of zoledronic acid increases the brittlety of the bone. So give it for 2-3 years. Then, if the calcium is less, you can supplement with calcium. But don't give a blanket cover of calcium always to every patient. That is nowadays more dangerous than not giving calcium.
So
Anyone wants to supplement?
yeah, absolutely correct. Because that is the point where stands when bone skeletal density is very low, less than 3.5, is less than 3.5, then we start with the teriparatide. That is the best way out, because anabolicity of the bone. And then after 1 or 2 years, when the bone is quite strengthening, that is very clearly written that this is 11% increase in bone density. Then you can start with a zoledronic and anti-resorptive therapy, or directly denosumab. So denosumab, that is a drug which you continuously you can give 6 months.
For longer period of time.
It is for all. Otherwise, for this drug, zoledronic acid, brittleness, and there's a fracture, jaw fracture. These are the complication which is seen off and on. That is very important.
But at the same time, please don't forget our good old friend insulin. Insulin,
yes.
Insulin also has got a very anabolic hormone, and insulin has got a tremendous effect on the osteoblastic activity of the bones.
Yes, absolutely.
It is strong anabolic effect.
Yes,
strong
it's
anabolic
very
effect.
strong.
So don't forget our good old friend insulin. That also needs to be continued along with these supplements.
Yes, absolutely true. Absolutely true. So, Dr. Subhash?
Subhash sir?
Yes. It was very nice going on, and I was just enjoying it. Dr. Sanjeev Medi has given his excellent inputs, and as our senior superior Supriyo Mukherjee sir has given some excellent thing to ponder on osteoporosis. I wanted to just draw attention on the other part of osteoporosis that I see clinically relevant in especially particularly area like Bihar, Assam, Bengal, where rampant use of steroids are there. for anything, people may jump on using steroid from village to the city and town. So I think when I see osteoporosis and diabetes, now I have I see people today also. I saw a lady using 4 types of inhaler with corticosteroid was prescribed somewhere long back, and she was having the similar case. So I think that part should be always discussed with the huge
Very important. Very
audience
important.
of Vijay of 90 people in this group. So that was one point. And then neuropathy. We must forget neuropathy, because neuropathy also will lead to fall and fracture. So we can protect them when we treat them properly. And the diet part and exercise, I think that is it's always discussed in every forum, everywhere, either it is patient or in a consultation, because we need to do weight bearing exercises. No, medicines
Yes.
are there, they will help, but why to land up in such situation? If people comes living with diabetes, should be taught from the beginning itself that they need to do some weight bearing exercise, and the diet, the protein, which is the most source of collagen, which is getting depleted. What you do, you don't do, you will get it no less in year by year. So that those things, I think, should be always focused once we talk on osteoporosis, other than the excellent drugs which we discussed.
Yeah, I'd just like to give one last input that no discussion of diabetes skeletal muscle is complete unless we discuss the Charcot's arthropathy. Because Charcot's arthropathy is not actually a true fracture. It is a combination of decreased bone density, neuropathy, musculopathy, and these vasculopathy also, endothelial dysfunction. So these all factors combine together and gives rise to Charcot's arthropathy. So Charcot's arthropathy is, many time we miss it, many time we think that the patient is having some infection and all, but always see the temperature of the swollen joints. If the joint temperature is less, it's cool, always think of Charcot's. If it is inflamed and red and signs of inflammation are there, then of course Charcot is not the thing unless it is infected. So every diabetic patient, every patient who comes to us with a especially swollen ankle or a swollen in the metatarsal bones, always keep Charcot's in your mind and evaluate the patients for Charcot's arthropathy, because the ankle joint is the most commonly affected. And as I've already told, that to treat Charcot's, you require the combination of orthopedics, endocrinologists, diabetologists, everyone has to give in their input. Because after all, it's a multifactorial cause which gives rise to Charcot's.
So wonderfully dealt with that, Charcot's. And that is the point which the tetraopathy, which started with a root, Dr. D.H. Root, way back in 1954, who described 154 patients of neuropathy, nephropathy, and retinopathy, to include osteopathy, like by Dr. Vadeda, form of tetraopathy, is one of the finest, a very wonderful and very turmoil-filled journey of diabetes and our academic acknowledgements and knowledge. So with this, with our esteemed colleagues and our esteemed panelist, co-chair, end the session of this session. Thank you so very much.
Vijay,
Over to
sir.
Dr. Vijay.
Thank you, sir. Thank you, Subhash sir.
Vijay, is there any chance that Dr. Badada has joined? It's already 10 o'clock.
But I think if he joins, it will be better. But I think Mehdi sir has filled the gap very well, and his scientific temperament, we salute his scientific temperament. And we are sure that RSSDI research treat is going to be a grand success under his organization.
Thank you, sir. I invite you all for the RSS research retreat.
Exactly, we expect similar things in
and by seeing Subhash
research retreat then.
By seeing Subhash sir, we are feeling the ambience of Goa and Maldives also, so that is also quite soothing. His wallpaper is so soothing. So moving ahead, and
He's in Goa, I think.
Mauritius.
He's in Mauritius.
So moving ahead,
It is in Mauritius.
before delivering the vote of thanks, I would like to invite Dr. B.K. Singh sir for his concluding remarks.
Thank you, Vijay. First of all, I really thanks all the panelists, all the speakers, and the participants for such a lively discussion. And I think all credit goes to Vijay and the team, Bihar team, for conducting such a nice program. Actually, we have thought that there should be a two-part in the CME. One part is for the students or the PG students, so that they can take part in the discussion. And second part is the from a person who is really needs some basic topics like I came to know that the osteopathy is really a very good discussion, and it is one of the part of supposed to be the part of the micromuscular complication of diabetes. But the question remains, and Supriyo Mukherjee had raised the valid point that when to screen the patient of diabetes when we thought that the skeleton is involved, and what should be the biomarker or what should be the test. As Badada said, the many bone mineral density test is fallacious or may not be the true answer to the skeleton involvement. So there should be some gap, or there should be some more discussion on this skeleton and the diabetes. And we really thanks Dr. Sanjeev Medhi, Dr. Sandeep Devasis, Lakhanji, and Dr. Indulkar for giving his valuable inputs. And we thought that in coming days, we will also expand this virtual platform to accommodate all the state chapter of East Zone and the Northeast Zone, so that we can be benefited from the discussions. So really thankful to the all, and hand over the mic to Vijay, and really Subhas, input of Subhas and Dr. Supriyo and Dr. Sehwal and all participants is really very, very, very good, and thanks a lot.
Thank you, sir.
Thank you, sir. Thank you for a wise statement, and thank you for your wonderful encouragement to us. Thank you, sir.
Thank you, sir. So really, we have a galaxy of speakers and galaxy of chairpersons and panelists who have given their input, valuable inputs, and particularly Dr. Sanjeev Medhi sir for filling the gap and helping us out in absence of Professor Sanjay Badada sir. We were actually somewhat nervous because today only Dr. Badada sir attended today's session. So I would like to deliver my sincere gratitude and thanks to our National President, Dr. Vijay Viswanathan sir, in his absentia. He is always instrumental in organizing such activities. I would also like to thank Dr. Badada sir in his absentia for accepting our invitation to deliver the talk. I would like to thank our chapter chairman, Dr. Supriyo Mukherjee, for always standing behind me for each and every academic activity and encouraging the team of RSSDI Bihar to deliver his best. I would like to express my sincere thanks to our expert panelists, Dr. Professor Manoj Indurkar sir from Rewa, Dr. Lakhan Singh sir from Chhattisgarh, Bilaspur, Dr. Sanjeev Medhi sir from Guwahati, and Dr. Sandeep Devasis Misra sir from Cuttack for sparing their valuable time and giving their valuable inputs and making our CME more interactive. I would also like to thank the postgraduate student who has prepared the case and presented it very well, and his mentor, Dr. Atul Vaid, for taking pain in sharing the case and delivering his best. I would also like to thank our esteemed delegates, esteemed faculty, to name a few: Dr. Professor S.C. Hassel, our chapter treasurer, Dr. Manish Prasad, and all of those who joined us today evening. I also express my thanks for technical and media partner 3.Pharma, who is always there with their technical team for smooth conduction of the program. And I would also like to thank all the RSSDI Bihar Live members. Without their participation, the CME cannot be. So I express my thanks to all of you. Now, before I invite you all for virtual dinner, let us have our national anthem, and then we will disperse. So, Anandi, for national anthem, we should stand.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा कलबंगा विंध्य हिमाचल यमुना गंगा उछल कलधि तरंगा तब युवना में जागे तब सुराईश मागे गाये तब जय गाथा जनम मंगल जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, Anandji. So now I am inviting you all on behalf of RSSDI Bihar for virtual dinner. So,
Thank you very much, sir. Thank you. Thank you for inviting. Thank you very much for inviting.
Thank you very much.
Thank you, sir. Thank you, and good night. We will meet with some.
Good night.
Thank
Good
you,
night,
Vijay,
everyone.
for wonderful coordinating, wonderful moderating the session. It is from my side, it's a personally thank you for your excellent and very excellent job. Thank you very much, Vijay.
Thank you, sir.
Long live RSSDI.
Thank you, thank you. Thank you, sir. Thank you, and good night to each one of you. Thank you, sir.
Good
Thank
night.
you.
Good night.
Good night.
Good night, sir.
Good night, everybody.
Good night, sir.